My genetic presentation will be on citrullinemia. Citrullinemia is an inherited genetic amino acid disorder. It causes an accumulation of ammonia and other toxins in the blood. There are two types, type 1 and type 2, both which can be fatal. Mutations occur at the ASS1 gene for type 1 and at the SLC25A13 gene for type 2. Physical effects of type 1 do not typically present until several days beyond the birth of a child. Initially, their features are typically normal and they appear to be healthy infants upon birth. Over time, the infants begin to experience lethargy, vomiting, seizures, may demonstrate difficulty feeding, and can even have loss of consciousness. There is a milder form of citrullinemia type 1 that may develop later in childhood or even into adulthood. Primary type 1 can be life-threatening to the individual affected. However, the milder form may result in severe headaches, loss of vision, issues with balance and muscle coordination, and lethargy, while some patients may show no symptoms at all. Type 2 primarily affects the nervous system and will often cause restlessness, memory loss, confusion, aggression, irritability, hyperactivity, seizures, and coma. These can be life-threatening to an individual affected as well. Both type 1 and type 2 are inherited in an autosomal recessive pattern. Both copies of the gene in each cell have undergone the mutation, although in most cases neither parent will have shown signs or symptoms of the condition. Type 1 is the most prevalent and occurs in approximately 1 in 57,000 people worldwide. Type 2 is much less likely to occur and is seen in approximately 1 in 100,000 to 230,000 individuals. The mutation of the gene disrupts the third step of the urea cycle, causing the prevention of the body to appropriately process excess nitrogen into urea. Therefore, nitrogen and other byproducts accumulate in the bloodstream and can ultimately cause severe damage to the nervous system. This pedigree illustration shows the inheritance pattern of citrullinemia. The potential risk that citrullinemia poses to family members is shown here. Parents of affected individuals are both carriers of one ASS1 variant and will have no symptoms, while siblings of affected individuals will have a 50% chance of being asymptomatic carriers, a 25% chance of not being affected or being a carrier, and a 25% chance of being affected. At birth, siblings of an affected individual should undergo immediate evaluation and be placed on a protein-restricted diet until a full evaluation has been completed. Genetic testing options for type 1 include single gene testing, multi-gene panel, and least often evaluation of ASS enzyme activity. Options for type 2 include molecular genetic testing, which can be single or multi-gene panels, or a Western blot analysis can be performed. Genetic testing would be highly recommended for type 1 citrullinemia patients within the first week of birth if the following symptoms are present: increased lethargy, somnolence, refusal to feed, vomiting, rapid breathing, stroke, increased intracranial pressure, increased muscle tone, and/or spasticity. Genetic testing should be encouraged at any age if recurrent lethargy, intense headaches, loss of vision, ataxia, slurred speech, or intellectual disabilities occur. In regards to type 2, which usually presents suddenly between the ages of 20 and 50 years of age, genetic testing is recommended in association with sudden onset of symptoms such as recurrent hyperammonemia and neuropsychiatric symptoms. Home tests are estimated to cost roughly $890. Cost of in-office testing performed by a specialist would depend on the rates of the facility in which they are being performed at. Early detection of citrullinemia is important in order to prevent liver damage and ultimately liver failure. If undiagnosed or untreated, the longest known survival rate is 17 days. In terms of treatment for citrullinemia, for an infant or a child at risk or diagnosed, they would start with minimizing the protein intake. Then they would reverse or minimize catabolism, in which the calories consumed should be strictly monitored or documented. And third, they would promote waste nitrogen excretion. They may use oral medicines such as sodium benzoate, sodium phenylacetate, and arginine. If the oral medications fail, they would then go on to IV medication or dialysis if necessary. And continued management for hyperammonemia or an amino acid analysis is required long term. The prognosis: if treated citrullinemia type 1, patients can live out pretty normal lives in terms of growth and development, although excessive values of ammonia in the blood can cause irreparable neurological damage. And these are my references.